Going live. Going live in 5, 4, 3, 2.
Hi, evening everybody. It's a great pleasure to restart these sessions that we had been doing for the last year. This is now the first of a month, the first monthly episode. We used to do them once a week. Now it's going to be once a month after popular demand, and it will be every third Thursday at 5 p.m. to 7 p.m. for our Cerebrovascular and Skull-Based Surgery Symposium. This is really the 31st session today on February 18. And of course, we're starting this series with a bang, as you can see, from our 4 spectacular cerebrovascular masters. With them will be later my fellow, Nicholas Kahn, who is Cerebrovascular Skull-Based Fellow, who will present a case to our 4 panelists before we get on to the Q&A from the audience, from you. I'm Jacques Morcos, a professor and co-chair here in the department doing cerebrovascular and skull-based surgery, joined by my co-directors of this course, Carolina Benjamin, who's assistant professor, director of our Keynes lab. Carolina does brain tumor and skull-based surgery at and Jackson North Hospital in Jackson, Maine. Mike Ivan, assistant professor, director of research, at the Brain Tumor Initiative, the BTIs. Mike does brain tumor, skull-based, and epilepsy surgery. And last but not least, Bobby Stark, co-director of endovascular and director of endovascular research. As you know, Mike Ivan also has been, my partner has been doing a very successful Wednesday series of sessions. And he's also moved on to doing it once a month, the first Wednesday of every month. So please tune in next March 3rd for advanced imaging of gliomas with Susan Chang. Again, Mike Ivan directing that course. For this session next month, it'll be skull-based. Join us with Paul Gardner, Juan Fernandez Miranda, Aaron Cohen Gadol, and Bill Caldwell for a very exciting session on skull-based. Stay tuned, and I will be letting you know what the exact topic will be. And if you're interested in pediatric neurosurgery, my colleague in pediatrics do once a month Monday session as well. Many thanks to the team that has made it happen all through the COVID year, last year, and also doing this for us today. And thank you, Ignacio, particularly for running this webinar. This is the website. You're familiar with it. If you want to watch any previously recorded sessions from last year, they're all there, including 2 sessions from our current panelists today that they did for us last year. You can go and watch them, of course, all for free. And you can contact us per email, Twitter, departmental, Instagram. You can see all that here. I thought for our monthly sessions, we'll do slightly new format. We will alternate cerebrovascular topic and a skull-based topic monthly. I will invite 4, as you can see, internationally renowned speakers to speak each 20 minutes on a topic that is usually complementary to each other. And we will follow that with generally a more junior person presenting one case for the 4 panelists to give their opinion. Then we, of course, open it up to you, the audience, for Q&A. So throughout the talks, please type in your questions in the Q&A box, and we'll make sure we will address most of them, if not all of them. I cannot have this session without asking us to pause just for a few seconds and reminisce on the loss of a giant in cerebrovascular surgery. Of course, Evandro de Oliveira, who was a teacher and a friend to many. We lost him exactly a week ago. May he rest in peace. And I know that his legacy will continue for generations to come. And I decided for this monthly series, I'm not going to waste any time introducing my speakers. I have re-invited the stars that were here before. I don't want to take any of their speaking time. You know that certainly today's speakers do not need any introduction whatsoever. They're welcome to introduce each other if they wish, or make fun of each other to spice it up, but they certainly need no introduction. I'm going to just tell you their names and what their titles will be. Robert Spetzler, who has a very weak internet connection, but luckily we have his recorded speech. He may be able to join us later. He's going to try. He's going to talk about first surgery of vascular malformations of the spine, from classifications to lesson learned. Dan Barrow, microsurgery of special aneurysms, giant, thrombotic, fusiform, blister, and mycotic. That should be a spectacular collection of cases. Fadi Charbel, my compatriot and friend of many years, evolution of bypass surgery for vertebrobasilar insufficiency, from recognition to techniques. Last but not least, Mike Lawton on innovations in bypass surgery. So you could not ask for a better lineup than this. And without further ado, so I think I'm going to stop sharing my screen. And Ignacio, I think you can load up the video of Dr. Spetzler.
Hi, Jacques. Thank you for your kind words. It is always a pleasure to participate in the University of Miami Cerebrovascular and Skull-Based Symposium. My title today is Surgery of Vascular Malformations of the Spine, from Classification to Lessons Learned, is an area that I am very, very interested in, and is, although seen very infrequently in our practice, one of great importance. I have divided these into a classification that's very straightforward, based on anatomy as well as pathophysiology. So they're divided into arteriovenous fistula, which are further subdivided into the extradural and into the intradural kind, and the intradural further subdivided into dorsal and ventral. Arteriovenous malformations are further subdivided into extra-intradural, and the intradural are further subdivided into intramedullary, midline, and lateral, and conus. The midline and lateral I had previously identified as central and diffuse, but Dr. Lawton pointed out that diffuse really doesn't fit, and so I think more appropriate really is the separation of midline and lateral which I'll spend a little more time a little bit later. So in a cartoon fashion, you can see them here: the extradural, the dorsal, the ventral, the intradural arteriovenous malformation, the intramedullary AVM, now called midline, the intramedullary AVM lateral, much more common than the midline one, and then anatomically specific, the Conus AVM. So for intradural arteriovenous malformation, as I mentioned, we have the dorsal as well as the ventral. Fortunately, the dorsal is much more frequent and very straightforward as far as presentation and treatment is concerned. They present almost unique, always progressive neurological deficit from venous hypertension. Only rarely do they hemorrhage. On angiography, you have slow flow, and you have two types, the type A, which is a single feeder, and type B, which are multiple feeders. As I mentioned, presentation is progressive myelopathy, and old nomenclature includes type 1 and long dorsal. Here is a dorsal single feeder example. You can see it here. There used to be a lot of controversy as to whether this fistula was extradural, within the dura, or intradural. There's no longer any doubt in my mind that these are all intradural. On MRI scan and on angiography, when it's performed, you see the classic picture of usually edema on the spinal cord, and on angiography you see these coiled vessels that sit on the back of the spinal cord with extremely slow flow. When we look at it, where it actually occurs, when you look extradurally here, you see this sort of collection of small vessels, which I will get back to, and why it was misrepresented. You see the coiled vessels if the dura is opened. And you see along the dura where nerve root enters, the actual site of the fistula. When you get the specimen from there, you can go from artery to vein, and really very straightforward. And when you take this out, then follow-up angiography shows no further fistula. Here's one, a type B with multiple feeders, same sort of presentation. And I've put these in this form so that they are upright. You see this conglomeration of vessels, which has often or previously been confused as being the actual culprit. But if you look at them very closely, you can see that this point and this point are the same. It's just that you have another artery to artery anastomosis to the one fistulous point. So all that required again is getting rid of this, and you're going from artery to vein. The uniqueness of this particular fistula is that they are under very high pressure. So if you look at the feeding artery pressures, when it's open and closed, that means you just shut off the draining vein. You have normal arterial pressure measurement. The draining vein, when it is open, can have pressure that's up as high as 60 millimeters of mercury. So that is the pressure that the spinal cord is being exposed to. When the fistula is closed, it is still an abnormally high pressure. The draining veins drain into the epidural venous system, which is at this, which is a fairly normal venous pressure. So you see there is still a significant increase in pressure even after the fistula is closed. The question is, why does that occur? So if we're looking at the venous flow here,
the fistula has been exposed.
We can see
ICG,
from the
intraoperative angiography,
ICG
one can see the
very slow flow into the venous
through
system.
the fistula.
We follow it long enough, we'll see it
With progressive visibility of the
slowly filling the
venous
coiled
drainage.
vessels.
A hallmark of this dorsal
We then go
fistula
ahead,
is its
do our
low
pressure
flow.
measurements,
Pressure recordings demonstrate the high
occlude
intravenous
proximally
pressure,
and distally, and then all we really do is interrupt that tiny
then
little fistula
coagulating
right
the
there. And
fistula
once
itself.
that is done, I like to cut it to make absolutely
when it
certain
is
we've eliminated
sacrificed
it.
right at the nerve
Then
root
this
entry
disappears,
zone,
and the
where
patient's
the nerve
progressively and
enters.
slowly
The
becomes
specimen can be
better.
obtained, which
AV fistulas. Your colleague was not able to treat directly, so at surgery, what you're seeing is this is the vessels that are feeding the fistula. This is the fistula coming out. These are the recruitment vessel. One clip across the fistula is all that is required. Now we only see pica filling and the normal vasculature. And when we look at the angiogram, the fistula is gone. And when we look at the spinal cord, this is the pre-op picture. And here's the post-op 1 year later, and he is back to walking. A profound difference. When we look at the ventral intraarterial AV fistulas, this was first described by Roberto Heros and called a type 4 back here. And these are very high flow fistulas, totally really different than the dorsal ones. And Merlin divided these into 3 types, the small, the medium, and large, which you see depicted here, which we kept. Here's a ventral type A, a small one. This is a young woman that was horseback riding and had several episodes of paraplegia. You see the artery of Domkowitz. You see aneurysm and fistula. This was exposed through a transthoracic approach. I won't show you the video, but here's the aneurysm that had obviously bled. You could see the artery of Adamkowitz coming up, and then the fistula and the veins. And really with this exposure, it was very simple to get rid of the lesion and eliminate the fistula. And follow-up DSA demonstrated just the normal vascularity. Type C is when they're very, very large. This was progressive paraparesis in a 45-year-old. And when you look at the caliber of the vessels, it is just astounding. And this is what it looks like at surgery. Here you see the vessels. This is anterior spinal artery. This is anterior spinal artery. One simple clip across the point of the fistula, and the lesion is gone. This is before the clip was applied. This is after the clip is applied. Extradural, intradural AVMs are relatively rare. They used to be called juvenile AVMs or metameric AVM or type 3 AVM. Our classification defines it by its anatomical appearance, and they can really cause compression, steel, hemorrhage. Here is a case of an 8-year-old. We did a laminotomy. She'd been previously operated on 3 times. You can still see the large component that is peridural, epidural. I used up all the glue that was available in endovascular suite after separating the lesion from the dura and injected it directly in order to be able to pull it out, and this was efficacious. This is a more typical kind. This is a little girl that has progressive myelopathy and spasticity, and you can see the compression of the spinal cord really rather dramatically. On angiography, you see filling of the fistula, the AVM, you see the drainage, you see the relatively large mass that is causing the problem in the spine with compression of the spinal cord. After angiography defines the lesion, I always prefer embolization, which really helps not only in decreasing the flow through the lesion, but when you're there, also identifying where you are in relationship to the preoperative study. So here we are, we're looking epidurally. Here's the component that's in the spine itself. And here you see the intradural component. And then we're going to go extradural because that's where the compression is. We're trying to preserve this nerve root. All our surgical maneuvers are designed to push the lesion toward the bone, away from the dura and the spinal cord, so that we're not causing further compression of the spinal cord. And then carefully, you can see the nerve root in here. I'm trying to determine whether we can preserve the nerve root or have to sacrifice it. But by staying right along the edge of the sleeve of the nerve root, we were able to preserve the nerve root and eliminate the fistula. Here you can see the pre-op compression. And post-op, you see that compression gone. And the post-op angiogram demonstrates absence of the fistula, and she's really better. Conus AVMs really are unique because they have both a lateral AVM, direct fistulas, they're peri and intramedullary, and they're always located at the conus. And surely that is because of the anatomy, where you have the basket of the spinal artery connections at the conus. That is, the posterior spinal arteries and the anterior spinal arteries are connected directly. And when you look at them, they present, as you might expect, because of their location, with both myelopathic and radiculopathic symptoms. And these have all been published. And you can have venous hypertension, you can have progression, venous compression, and you can have hemorrhage. Here's a classic example. This is a professor from Texas. She presented with a subarachnoid hemorrhage, which was not sufficiently localized that she underwent a regular angiogram 4-vessel study of the head. And then when she developed some unexplained symptoms, slower down, this lesion was discovered, as you can readily see, right at the conus. She was neurologically intact at this point. This is what the angiogram showed. And then we performed the laminoplasty. My colleague, Dr. McDougall, had attempted to do some embolization. It was of limited, but here you can see the conus, you can see the nerve roots, and then with sharp dissection, non-stick bipolars, we work at the bottom of the conus and along the nerve roots, removing the arteriovenous malformation. And it's really a tedious process because you're trying to maintain the normal vascularity while removing the Conus AVM. Cutting the phylum and lifting the AVM out right between the nerve roots. And then doing ICG and not seeing any further fistulous component. Post-op, she has full strength. She had mild sacral root anesthesia. She had urinary retention requiring straight cath. She went home on post-op day 4, came back 6 weeks later. Urinary symptoms had resolved, anesthesia was improving, and the DSA showed no residual at 6 weeks and none at a year follow-up. So for the Conus AVMs, they are a distinct entity, have unique angioarchitecture, can present with symptoms because of their location, both of radicular and myelopathic nature, and 43% were stable, 43 neurological improvement, with a cure rate of 88%. Most important, all ambulatory patients remained ambulatory, and of those that weren't at the start, 75% became ambulatory. Finally, I want to end with observations, thoughts on management of these fascinating intramedullary AVMs. The midline and the lateral, located because of where they are in relationship to the anterospinal artery. Here's their presentation. Again, these have all been published. Bleeding naturally is fairly common. And here are the results of treatment with really remarkably good results considering the lesions we're dealing with. So here's a midline AVM, 2 episodes of quadriplegia. When you look on the AP, you can see the anterior spinal artery, and this is right in the midline. When you look at the lateral, the AVM is in front. There's a large venous aneurysm associated with it. And so the only way to can really treat this is with a midline myelotomy. And that's what we're seeing here. We go straight down the midline. Obviously, we have to be relatively careful because the blood supply is coming from the front, and we have the large aneurysm posteriorly. We go tediously around the edge, making every effort to not take any of the spinal cord. And then we're all the way in the front, intra-arachnoid, cutting off the vessels that are feeding it from the anterior spinal artery. And that's what we're left with. And that's what it looks like afterwards. She made an excellent recovery. Here's one of the intramedullary AVMs. You can see this patient was treated with repeated embolization and focused radiosurgery. She had significant deterioration after her last embolization, and we will be able to see why in a second. Here you see the injection. And when you look at the time of surgery, you can see the coiled vessels. First, notice how it's moved over, but then look at all the onyx that had gone into the subarachnoid space, further pushing it over. So that was pre-op. Then post-op, you can see much of the mass effect had been eliminated. She did not get any worse from surgery. This is a classic appearance. It's a little 12-year-old. You can see the edema in the spinal cord, 1 episode of quadriplegia. When we look at the studies, it's hard to determine whether there's really anything you can do surgically. This important here is this the midline. That's the anterior spinal artery. And you notice this is off the midline. That's why we call them lateral. And that's important because of our approach for surgery. This patient was not embolized because when a challenge test was done, he became neurologically worse. This is what we see at surgery. What's important is this AVM, even though there's a significant component that goes intramedullary, has a very large component that's extramedullary and pushes the spinal cord over. We can rotate the vessel. We can do repeat ICG to help us identify where the residual fistulas components are. But what is unique is that we can cut these vessels that go into the spinal cord after bipolaring them without the same sort of sequelae that we fear when we try to cut an AVM not at the edge, in the head, where we get uncontrolled bleeding. So, and this is how it comes out. No longer fistulous component on ICG. And there's the post-op, and he ended up doing remarkably well. The last case I want to show you is really a severe form. This is a patient from the south coming in a wheelchair from severe myelopathy. And it's very hard to see whether there is really any normal spinal cord left. We could see the mass occupying the entire spinal canal, pushing the spinal cord over. This patient was embolized by Dr. Albuquerque. Beautiful job. Here's the pre-embolization. Here's post-embolization. And this cast will help you at the time of surgery to know where you are. It's another roadmap that we can utilize. So at surgery, we see the lesion. We can see how far it has pushed over the normal spinal cord. And again, we go and we cut along the edge of the pia, going across vessels that are going into the spinal cord and getting away with it. Obviously, the non-stick bipolars here are critical, as we don't want to rip these fragile vessels from the spinal cord itself. When we see the onyx, we know where we are in relationship to the cast. When we do intermittent ICG, we can see where there's still a significant fistulous component, so we can direct our attention to that spot. And we just keep working around. We can go very lateral. We can go between the nerve roots. There are usually a few nerve roots components that have to be removed. And once we remove the AVM, we again check to make sure there's no longer any component. She was neurologically stable after surgery. Post-op angiogram showed a tiny little something extradurally that glue was put in. And then a year later, she had a repeat study, walked into the office. This is one of the most grateful patients I have encountered. Remember, she came in a wheelchair, severe myelopathy, and she walked in without aid into the office a year later. So what is unique is that we can cut across an AVM like this and not have uncontrolled bleeding. And I think that's an observation that allows us to treat these lesions successfully. So in conclusion, I think microsurgery and embolization remain as the gold standard for these intramedullary AVMs, recognizing the ability to obliterate without complete resections has important implications for treatment, and the classification that I presented that is based on anatomy and pathology, I believe has merit. I thank you for your attention.
Thanks very much. Ignacio, can you activate my video? Ignacio, can you, yeah, thank you.
I was doing it.
Yeah, very good. Thank you. Again, for the audience, please, I saw some questions in the chat box. Put them in the Q&A box and we will address them at the end because I don't want to delay our speakers. I promise you we will address most of them, if not all of them. If Dr. Spetzler will be able to join us later, I'm sure he'll be able to answer some of the questions that came up after this fascinating talk. So with no further ado, I invite Dan Barrow, of course, the chair at Emory, to unmute his microphone, share his slides, and talk to us about those funky, unusual aneurysms that we all encounter in our practices and how he handles them. Dan, all yours.
Thank you, Jacques. It's really a pleasure to be with you again. I want to report that I have no financial disclosures. The only disclosure I have is that I think every patient I'm presenting ended up in my office because they thought they were coming to the Barrow Neurological Institute, and that's why I ended up treating them. These aneurysms that I'm going to talk about really challenge the skills of the neurovascular surgeon, but they're kind of fun aneurysms to deal with. They require very innovative clipping strategies and sometimes require a bypass because there isn't a good endovascular or microsurgical option for managing them. So I'm going to share some cases that go into these different categories. Giant aneurysms have an incredibly horrible natural history. It's worse than many cancers. The difference being is that this is a potentially curable problem. They can present with mass effect, and they can also hemorrhage. And the life expectancy when you're diagnosed with one of these is very short. This is a case that required a deep hypothermic circulatory arrest, something we don't do as often as we used to, but this is a case where even in the endovascular era, my colleagues didn't have a good option. And we did this under deep hypothermic arrest. And this is the result we got, which I think would have been really impossible to have achieved without the 40, 50 minutes of circulatory arrest one gets with deep hypothermia. Sometimes we have to be creative. This is a very large vertebral aneurysm arising at pica that's causing brainstem compression. So do not hemorrhage. You can see the aneurysm on the angiogram, and on 3D, you can notice that pica comes really right out of the vertebral at the origin of the aneurysm. And again, there were not felt to be any good endovascular options. So at the time of surgery, you can see the huge mass distorting the cervical medullary junction. And we take advantage of the fact that both picas are near each other and bring them together and perform a side-to-side pica bypass, which is a relatively straightforward bypass. And then we can trap the vertebral artery, occlude the pica, and decompress the aneurysm. And you can see on ICG that the pica fills through the contralateral and through the bypass. And here's the intraoperative angiogram showing that patent bypass. Not infrequently, giant aneurysms present with mass effect. And this is one of the problems with endovascular options. Although they're wonderful in many instances, it often doesn't eliminate the mass effect. And in this case, you can see that we've removed the anterior clinoid process. This is on the left side to decompress the optic nerve, remove the anterior clinoid, open the dural ring, and we're going to now clip this aneurysm with a variety of clips using a fenestrated clip because we want to increase the closing pressure distally, purposefully leaving part of the aneurysm passing through the fenestration. It's very important to decompress the optic nerve first so that you can manipulate it, not tethered by the falciform ligament. Now these clips are clearly across the aneurysm. I've trapped it during the time that I'm doing this with burst suppression, but even with clips across it, one of the problems you encounter with these giant aneurysms is that when you puncture it, you see that there's blood still getting through the clips. And so a fenestrated clip is now used to reinforce those with a fenestration encompassing the optic nerve and the optic nerve well decompressed. An ICG demonstrating patency of the artery. The intraoperative angiogram demonstrates that the aneurysm is obliterated completely, and this patient enjoyed significant relief of their optic neuropathy in the early postoperative period. Now, sometimes giant aneurysms, particularly if they're thrombotic, are very difficult to get rid of completely. And as I say, the enemy of good is perfect. This is a large aneurysm in a patient who was elderly that presented with seizures from mass effect. And at the time of surgery, you can see this is on the left side through the Sylvian fissure. It's a very complex multilobulated aneurysm. We've opened the Sylvian fissure. We're identifying the M1 segment, which gives rise to this very complex aneurysm. And I begin by just clipping the proximal portion of it, which is soft. And you'll notice that as we start working on this and manipulating it, it is a rock, literally like a stone. So I briefly decided that after showing that I had flow, that I would crush the neck of this with a hemostat, an old trick that I used in the past. And you'll notice that I quickly realized that that probably is not a very good idea. It doesn't collapse. And I decide that, again, as I said, the enemy of good is perfect. And I decide to use a series of fenestrated clips to occlude the portion of the aneurysm that is not calcified, and leave that calcified portion there. This was not a young patient, and so I thought this would be a better option to have an imperfect postoperative angiogram, but a patient with 4 limbs moving. So you can see the fenestrated clips being put on, eliminating every part of the aneurysm that is soft-walled in any way, and then very carefully wrapping the aneurysm at the end with muslin. Clearly knowing that I left some residual, but the muslin wrapping is used to initiate some scarring, and not as a perfect a solution as complete clipping, but this patient actually did very well, and is still living, and has never had any trouble from this. And you can see the preoperative and the intraoperative angiogram that we haven't eliminated it, but I think we've reduced the risk of the aneurysm. Thrombotic aneurysms are generally very large, but they don't have to be. This is a middle cerebral aneurysm that has thrombus within it, and it does complicate the clipping because the clip oftentimes will slip down, and we often have to open them and remove the thrombus. But frequently they can be quite large and quite dramatic. This is a patient that presented with profound visual loss and personality changes from this giant thrombotic aneurysm that actually turned out to be extremely simple to treat. And so you always have to think about the simple surgical options. This is the part of the aneurysm that filled. And you will see in this video that the neck is actually very, very narrow. This is the left carotid. There's a side angle clip that is being put in and then rotated so the blades are parallel to the axis of the carotid. And that's the treatment of the aneurysm. That's all it took. It would have been foolish to do anything other than surgery. Now what we can do, now that the aneurysm is occluded, is open it and decompress the optic apparatus. I think at this point, the mistake that many make is to try to, again, achieve a perfect follow-up imaging study, and you really don't need to remove all of the thrombus. We've removed the blood that was trapped in the aneurysm, and now we're using an ultrasonic aspirator to decompress the optic apparatus. But I think if you try to pull the entire aneurysm down and remove all of it, you actually will cause more harm than good. So we have made sure that we've really decompressed the optic nerve and the chiasm, which you can see here that we have. And this is another patient that enjoyed dramatic relief in their visual obscurations that were improved by this. And you can see we didn't remove every bit of it. Thrombotic aneurysms can hemorrhage. They do hemorrhage. And this is a case of a horrible hemorrhage on the dominant hemisphere. Here we're opening the lamina terminalis. If one carefully opens the cisterns and the lamina terminalis, you really don't have to use any fixed retractors. You can now see the aneurysm coming into view with the surrounding intracerebral hemorrhage. And as we trap the aneurysm, we clip the M1 and both M2s under burst suppression. We can now open the aneurysm and again use ultrasonic aspiration to perform an aneurysmorrhaphy to get rid of the mass effect, but also to achieve a situation where we can actually clip the aneurysm. This aneurysm would not have accepted clips. We use a tandem clipping technique, a fenestrated clip, and then a clip to clip that portion of it. And now we remove the rest of the mass and decompress the brain. And despite a terrible hemorrhage in the dominant hemisphere, after clipping this aneurysm, removing the blood and removing the mass effect, the patient made a very rewarding recovery and survived this well. You can see the follow-up MRI really looks much better than you might expect for such a complicated problem. This is a 36-year-old man that had this proximal M1 aneurysm that was coiled at another institution and lost to follow-up. He presented to us 4 years later with this intraluminal hemorrhage, which you can see here, and massive enlargement of this coiled aneurysm. And just to demonstrate that you never are too old to get advice, I actually showed this case to both Jacques Marcos and Michael Lawton to get their opinion. You can see on the angiogram, the red dots outline the mass of thrombus. And notice the lenticulostriates spread over the top of it, and the high-grade stenosis where the little bit of the aneurysm is filling. We decided to do a radial artery bypass graft to the M2 segment, and then actually occlude the aneurysm distal to the neck to reverse flow, to be sure that we fill these lenticulostriates and create a blind sac. And here you can see the postoperative angiogram showing the bypass filling well. Here you can see that the lenticulostriates outlined by the arrows are filling beautifully. And the aneurysm indeed is a blind sac and has completely gone away. And here, with permission, is the picture of that patient who made an absolutely perfect recovery. And I do thank Michael and Jacques for lending their thoughts, because they both recommended this is what I do. These things aren't always simple. This is a thrombosed basilar tip aneurysm. And here I'm going to demonstrate one of the problems you can have. This is on the right side. We're exposing the posterior cerebral artery here. This is underneath the third nerve, exposing the basilar trunk so that we can put a temporary clip on. One of the problems with thrombosed aneurysms is that as you start to clip them at the thrombus interface, you can tear and you can see the bleeding. I've torn the neck of the aneurysm. You can see the bleeding behind it. And so I'm going to put a little piece of cotton over that, which is very absorbent and allows me to compress that and stop the bleeding. I've seen the lenticulostriates. And now with the temporary clip on the P1 and the basilar, I open the aneurysm and I'm going to remove the thrombus, probably what I should have done initially. And you'll see that the contralateral P1 is occluded from the thrombus. And as I do an endarterectomy, basically, now you see back bleeding from the P1. So I'll put a temporary clip on the contralateral P1. Now the basilar apex is completely trapped. That little piece of cotton is now being clipped to the little tear that created at the thrombus interface. And again, using a so-called tandem clipping technique, we're able to get rid of this aneurysm, take off the temporary clips. Doppler indicates that the posterior cerebrals are open, and ICG shows patency of the vessels, and a good outcome. Fusiform aneurysms are very challenging. There, again, aren't a lot of good endovascular options and often require surgical techniques. Sometimes you can reconstruct them. This is a fusiform aneurysm of the middle cerebral artery that we explored through the Sylvian fissure, and we're able to reconstruct. A couple of tips. First of all, notice that we're trying to save all the veins. Cauterizing with the bipolar under constant irrigation to shape the aneurysm and shrink it is a nice technique. A temporary clip is now put on to soften the aneurysm, and a series of clips are used to reconstruct the lumen of this very fusiform and odd aneurysm. It's in an odd location and an odd shape. It's certainly not a typical saccular aneurysm. The fenestration is used to make sure that the distal end is not compromised. The temporary clip is removed, and we clip that portion now passing through the fenestration, and ICG will indicate that we have spared all the veins and that we have maintained patency of the M1 segment there. In the angiogram preoperatively and intraoperatively shows a really nice result with complete reconstruction of that. That's not typically possible. This is a patient with a duplicate middle cerebral artery and a fusiform aneurysm that you can see better on the 3D. This is really impossible to reconstruct. And in this case, we trapped that aneurysm and then did an EC-IC bypass using the superficial temporal artery, which you can see here coming in. Here's the anastomosis, and you can see the bypass filling the branch that we sacrificed. Now, sometimes we can use both microsurgical and endovascular treatments. This is a young guy in his 30s who has this odd fusiform aneurysm. And notice that there's a middle cerebral branch coming out of the dome of the aneurysm. This must be a dissection. He has good superficial temporal artery. So we initially did a bypass to that branch that was coming out of the aneurysm, but it really was not a clippable aneurysm. So after the bypass, you can see here the clip has occluded that vessel, and my colleague Jacques Dion put a flow diverter in, and you can see that within minutes, the aneurysm is completely occluding, and the external carotid injection shows the bypass fills the branch that came out of the aneurysm. And finally, what I want to show you in this category is another endovascular and microsurgical treatment. This is a 15-year-old that presented with a subarachnoid hemorrhage. He has this odd fusiform dissection, is probably what this is, dissecting fusiform aneurysm. You can see on the 3D that it is very complex and really no good endovascular or microsurgical option. So in this case, our plan was to do a radial artery bypass, and unlike the other case, to actually do a proximal occlusion and reverse flow into the aneurysm, hoping that the decreased perfusion pressure would heal it. What happens sometimes in radial artery bypass is the intraoperative angiogram showed that he had horrible vasospasm. We infused vasodilators, but I was uncomfortable occluding the middle cerebral artery intraoperatively. Postoperatively, the day after surgery, he tested positive for COVID, became highly febrile, and we nursed him for 15 days. Fortunately, the 15-day angiogram showed that his bypass actually became quite robust. We did a balloon test occlusion, which showed that the bypass filled his cerebral circulation extraordinarily well. And then my colleague, Michael Cawley, went back and coiled the aneurysm. And in follow-up angiography, it has completely thrombosed. So another example of working together with your endovascular colleagues to find solutions. Infectious aneurysms are very interesting. They're rare and more rare now that we don't have as much rheumatic heart disease, but they're challenging. And the treatment is always, with rare exceptions, unless they present with a life-threatening hemorrhage, is to treat them with antibiotics, and they will often resolve. But when they don't resolve, we need to find neurosurgical treatments. This is another interesting, a duplicate middle cerebral artery mycotic aneurysm. You can see it's a tiny little thing, and we treated this patient with antibiotics. And over a course of a week, we checked them every week. You can see that this is dramatically increased despite antibiotics. And again, there really isn't any way to reconstruct this. It's proximal, and we would have lost that branch. This patient had only an anterior branch of the middle cerebral artery that was adequate, but it was perfectly fine for us to do a bypass. You can see we've trapped the aneurysm, and the temporal artery completely fills that robust vessel and got rid of that aneurysm. And finally, I'll finish with blister aneurysms, because these are really challenging for all of us, endovascular or microsurgical. This is a blister aneurysm of the A1 segment, and sometimes we can actually clip these. And this is an example. This is through the left side. You can see that we're going through the, carefully microdissecting through the clot from the hemorrhage at the carotid bifurcation. There's the blister aneurysm. These things are like wet tissue paper in their consistency. So very, very carefully making sure we're sweeping the perforators out of harm's way. And in this case, using a little side curved clip to clip that portion that obviously bled. You can see all the subarachnoid blood around the rupture site. Obviously, these aneurysms occur at a point where there is a disease within the vessel itself. And so clipping gets rid of that part that has bled, but I always wrap these with muslin just because I'm concerned that the vessel itself is diseased. And you can see the muslin wrapping. I think it's very important to do ICG, and we also do intraoperative angiography to be sure that we maintained patency. And my last cases will demonstrate why that is. Another option for these blister aneurysms is sometimes you can use the Sunt clip graft. Here intraoperatively, you can see the anterior clinoid process has been removed. Here's the optic nerve, and the arrow is pointing to the blister aneurysm. The Sunt clip graft, you can see here, I usually reinforce it with a little tiny piece of cotton and then put this clip graft around it. It encircles the aneurysm, the entire carotid. The problem with these is that they only come in certain sizes, but you can see here that they encircle the carotid and they offer a great option. The technique I use more often for these is Gore-Tex clip graft wrapping, which I must give credit to Robert Spetzler. He's the one that kind of turned me on to this, but this is a great technique. Here we are from the left side, opening the lamina terminalis to decompress the brain to minimize the need for retraction. Here's the blister aneurysm on the carotid artery on the dorsal surface. We're trying to stay away from the aneurysm, and I'm now taking a piece of Gore-Tex that I've cut to the appropriate length, and I'm wrapping it around the carotid, kind of like a diaper. You can see the bleeding site right here, which we try to stay away from. These things are treacherously fragile. And now we just lift it up and barely try to cinch the carotid artery. And this is where, this is the critical part, to make sure that you've narrowed the carotid enough to get rid of the aneurysm, but not occluded the flow. And I use every means possible. I use ICG, I use microvascular Doppler, and we also use intraoperative angiography. And I will show you, here's the intraoperative angiogram showing that the carotid's patent, but here's a case I want to show you where I had a problem. Here's a blister aneurysm. I did that same treatment. The ICG looked perfect. But the intraoperative angiogram, notice how narrow the carotid is, and notice the delayed flow in the middle cerebral artery. Seeing this intraoperatively, I immediately went in and moved the clip 2 millimeters more proximally, repeat the angiogram, and now I've got great flow. So the ICG can mislead you in these cases. Final case I want to show, another blister aneurysm at the origin of pica. In this case, what we did, this is on the left side. This is a far lateral approach. Here's pica. We've occluded the vertebral at the aneurysm, right at the origin of pica. So what we do now is we cut pica, we spatulate it, make an opening in the vertebral artery proximal to where pica originated, and reanastomose pica into the vertebral artery proximally. And here intraoperatively, using Doppler, here's the reimplanted pica. You can see that it's filling beautifully on ICG, and the postoperative angiogram shows the occluded vertebral and this very robust pica, which I don't think you could have sacrificed, that we have reimplanted into the vertebral artery. So those are some of the thoughts I wanted to share. Again, I appreciate the opportunity to be invited as a speaker again. And Jacques, congratulations on a fine series that you put together.
Thanks, Dan. Fantastic fantastic selection of tough cases and beautifully done, of course. Quick question, muslin gozomas. I have a horrible case of a muslin gozoma around an A1 blister that I put on, and this poor woman is going through steroids, myopathy, and didn't respond, and the gozoma goes up and down. I have her seeing a rheumatologist. She's on immunosuppression. Have you ever seen, they're reported, they're rare, but have you seen it?
Oh, yeah.
Muslin use?
Yeah, I've got a couple of patients I've been managing for a couple of decades with intermittent steroids. And I will tell you that I have actually reoperated on a couple of them, and that is not a very rewarding experience either. And so I try very carefully to avoid the use of muslin anywhere around the optic nerve, the oculomotor nerve, because the brain can, if they get seizures or something, we can treat that medically, but optic neuropathy or third nerve palsies from a muslinoma is treacherous. It's horrible to treat. And so that's why I said that it is an imperfect way to treat an aneurysm, but in some cases, as I also said, the enemy of good is perfect. I do think it plays a role, but you've got to be very careful. It can be a horrible problem.
Yeah, it can indeed. Thanks, Dan. We'll save questions again from the audience till the end. Now I'd like to invite Fadi Charbel to summarize for us his at least 2 decades of thoughts on posterior circulation, bypass, and Fadi has a fascinating story about how he went about thinking about this and what he's done about it. Fadi, go ahead.
Yes, thank you, Jacques. Well, first of all, I want to really congratulate you, Jacques, for pioneering this educational series. It has been, I know, a great hit everywhere, certainly with our residents, and keeping up with it. And it's a treat to be back with you and Dan and Robert and Michael, wonderful colleagues, to do this. So really, congratulations. And I really appreciate the title you selected. We know each other well, but Jacques, one of his many geniuses is sometimes he knows his speakers more than they know themselves, and actually he selected that title, and I'm gonna have a good time going over it. So. Starting with the disclosures, my disclosures are related to the flow probe. I do not have any financial interest in the Nova flow technology any longer. I used to many years ago. But before I start, I really would be amiss if I didn't recognize and acknowledge our wonderful Cerebrovascular team, starting with the faculty in alphabetical order, really. You all know them. Ali El-Araj is the chief of the endovascular section. Sepi co-directs the vascular program with me and is just superb in so many ways. Gersant Atwal is also the on the endovascular and open vascular program with us. Wonderful rising star in neurosurgery, vascular neurosurgery. And then our fellows. And every year we get phenomenal fellows, and this year, Matt Koch, and they contribute in so many ways, including ideas of how to do things better and really save our rear ends. And I'll show you an example of that with Matt. Our residents, obviously very biased towards cerebrovascular disease, so that's why I'm calling them cerebrovascular residents. In particular, I want to highlight our chiefs, Nauman Chowdhury, and also Amandana Mani, Babahani, and Laura Stone McGuire. So in some of the cases that I'll show you, they have come up with ideas to do the surgery better, and it's phenomenal. They're what I call the spotter. And all of you that know the analogy, there's a sniper who's got this tunnel vision, and then there's the spotter. The spotter has many roles, and they've been phenomenal spotters. So evolution of bypass surgery for VBI. I'm going to weave this as a personal journey and with case examples. and put out for you that there is tremendous opportunity for us in neurosurgery within this realm of the vertebrovascular ischemic disease. I'll start the surgery with this case. You can see the slides are old. It was towards the end of my residency, my research year. This man presents with a VB stroke. The carotid injection shows flow going down his basilar. The vertebral injections don't show much flow going up the basilar. It's unclear whether it's an occlusion, a stenosis, what to do for this man. The stenosis was an attempt made to reopen it. It failed. Actually, I did the autopsy myself, and it's a shame that it's difficult for our residents to do that nowadays with all the rules. But learned a lot from this case, and I was fascinated by it. And I would say this case is responsible for my interest in specific interest in pathophysiology of cerebrovascular disease in general, and more focused on the vertebrovascular disease. That was really what really got me hooked on this entity. So I wondered what happened and what would be a better treatment. And I started with this isolated posterior circulation model in the lab. Would take fresh cadavers. I'll create a stenosis like you see here with a noose. There's a needle that measures pressure like you saw done with Robert, and clip the PCOMs and create a stenosis and see what happens after a bypass. And what was not obvious initially, but obvious afterwards, is that the bypass improved the pressure distally, as you can see here. That's the pressure. It goes up when the bypass is opened. The bypass is to the PCA, but the flow in the mid-basilar then decreases. And then when I close the bypass, paradoxically, or so it seemed, the flow in the basilar improved. So what's going on here? So I sat down and thought about this, and that's the first thing I wrote, is kind of this basic hemodynamics application to bypass surgery. And you know, it's interesting to look back at things you wrote more than 20 years ago. And one of the key things that I started with is that flow is generated by a pressure gradient. And I postulate that in vivo, the blood is going to take the shortest route between the artery and the vein, being really the two poles of this pressure gradient. And then I wondered if there could be scenarios where the posterior circulation would be so isolated with so little collaterals, PL branches, et cetera, where there would be a true hypoperfusion problem. And I kind of drew up what I think it could be. And I wonder if these scenarios, they could be a zone where if we were to bypass, things could get worse, where we could create this no gradient, no pressure gradient zone that is abolished by the competing flow, for lack of better terms. So this was all thinking in my head. And then I had the opportunity to move to Illinois, and I moved there because my chair at the time, Jim Hausman, was recruited there, but also because of the School of Engineering. And I wanted to pursue these ideas through computational modeling. And we've been doing that, put this program together, the Canvas program. We worked on all these modalities, acquisition, flow measurements, and so forth, and learned a lot. So case 2, this man comes in. Now I'm towards the end of my chief year. Same story, VB disease. The carotid fills the vertebral system through the basilar PCAs and goes down, and then we don't know what happens. Is this man hypoperfused? Does he have enough? What do? We did not have any other ways to treat it, and the decision was made to perform a bypass to add flow from the superficial temporal artery, and the flows are measured here at surgery. So the STA is in red, and the recipient is the superior cerebellar artery in blue. Couple of points, you can see that the flow in the superior superficial temporal artery in the scalp here is very low, and here it goes up tremendously. That's the cut flow. You all know that by now. Vessel is clamped, the bypass is performed, and the flow of the SCA did not increase. And you're familiar with the cut flow index idea that we published multiple times. And you see that this STA that can deliver almost 70 cc's of flow is only flowing in the single digits. So clearly this bypass is not working. That's what we call a type 1 problem. And the purpose of this bypass ostensibly was flow augmentation. No flow augmentation occurred. And the reason, of course, is this patient did not need it. So that's a type 1 problem. So this is what we learn is that if we measure flow at surgery, we can find out that the bypass didn't work, and we can start to think, well, why did that happen? So data is helpful. So now I'm a junior faculty, and this lady shows up. She has crescendo VBI symptoms, and if her pressure drops below 180 millimeters of mercury systolic, she becomes stuporous and lapses into coma. So we're only keeping her barely awake at a pressure of around 200. You see the multiple hits that are evolving, and here's the pathology. Mid-basilar stenosis, isolated circulation like you saw in my experimental setup. Nowadays, we would consider angioplasty, which was not an option at the time. Gerard de Brun, which is the pioneer of endovascular, could not do it. And he said, Fadi, you got to do a bypass. I did it with the trepidation of really thinking of what is probably going to happen. Here's the bypass. Here's the recipient, the PCA. Here's the SCA. That's the old version of the flow probe. Here's the anastomosis measuring the flow afterwards. So here's the angio after surgery, bypass from the STA to the PCA, fills the top of the basilar, right PCA left, and the superior cerebellars. But injecting from below, you can see we don't have much top filling from below, and it peters off with later injections. And sure enough, a couple of days later, she had a neurological deterioration consisting of mid-brain basilar pontine symptoms that got worse, and the angio revealed that the basilar occluded, as we would have expected from the results of this setup that I showed you. So I attempted to reopen this basilar. I went transorally. You see the drilling of the clivus, the VB junction, but this basilar is so high, the clot was so high I could not reach it. I'm at the pituitary right now. You barely see the beginning of the clot. So I closed her up with a fascia lata graft anteriorly, flipped her, and then went pretemporal, transtentorial. Here's the carotid, here's the third nerve. And you can see that the balloon that we had available to us for an angioplasty, I thought I'll just put that balloon in the basilar and suck the clot out. Couldn't do it. So then here's the clot in the basilar. So I opened it, I did an endarterectomy. You can see the lumen is clean, stitched it closed, but I could not keep it patent. But the saving grace is that she had that bypass. And here's the early flow measurements of that bypass. She had about some 40 cc's in the bypass. She made it. She had deficits, but she was awake, she was interactive, she needed a wheelchair. This is 10 years afterwards. Here's the angiogram, still fills, but it fills nicer and bigger. And now we can measure flow with de novo MR. And this bypass has a tremendous amount of flow in it, and it's 91 cc's of flow in this bypass. She's still alive today. Her family enjoys having her around. So what did we learn here? Clearly, a bypass across the stenosis is not a good idea. And the reasons for that is that it abolishes the pressure gradient. Okay, so what next? This man shows up now a little bit later. He has this horrible problem, this basilar dolichoectatic aneurysm, presents with a combination of mass effects and perforator issues, deteriorates, and the treatment for that is really difficult, but generally it's an inflow problem. It's a disease of hypertension. So we occluded one of the vertebral arteries, still had flow in it, did not get better. And I endeavored to then reduce flow through the basilar by using this exact same phenomenon that I saw in the experimental setup, but in this case to the good, to help the patient. So now I want on purpose to reduce the flow through the basilar by putting a large vein graft to the PCA. And sure enough, it cuts the flow into the basilar as measured right here with the NOVA flow probe. Now the flow in this basilar is about 50 cc's. The normal basilar flow is about 180. So that's great, we thought. Except the patient started to get worse, progressive deterioration. angiogram patent, on anticoagulation, and it took a while to understand the problem. So when I point out to you right here that we're starting to see what the problem is. Here's the waveform. Flow is 49, but with every heartbeat, there is a pause. The flow goes down to almost zero, almost negative even. That is highly abnormal for the circulation. Anything above the aorta going to the head, you should not see that. The flow should always be antegrade and always, never reaching zero. So I thought, okay, if that's the problem, how about I occlude the other vertebral artery? But before that, let me show you this problem. So this is the patient before. The carotid is the big flow. The basilar is the other one. And they're flowing in sync. And with about 180 degrees phase shift to the sinus, which you see here. After the bypass, the carotid still looks good. The basilar is reduced and is counteracted by the flow going up the basilar. So clearly is that problem that is occurring right here. So took him to the MR, inflated the balloon in the MR. That was a MR compatible balloon. And lo and behold, the flow reversed. It's the same flow in absolute value. And the patient woke up, started to improve in the MRI. It was ambulatory the next day. After 6 months, the aneurysm thrombosed. Here he is, the angiogram. This is now the NOVA scan. And through that vein graft, he's getting about 180 cc's of flow. So fantastic result. He did great. And he lived for a long time. I followed him. And then many years later, in 2013, I was given a lecture to the Smith Society. It's a society of engineers. And I give this talk and I show this case and I tell them, look what happened. I'm not sure what caused that. And I showed him this picture here. And this guy, Georgios Varsos, was finishing his PhD at Cambridge. He says, you know, that's what I'm working on. The problem you're dealing with is the cessation of the diastolic blood flow. And there's a closing pressure. It's like hysteresis, and the flow will just drop dramatically, and that's not a good thing. And when I graduate and I publish this, I'll send you the paper, and here's the paper. So what does that tell us? Is that the problem is someplace, but often we look where it isn't. It's like the story of the guy who lost his keys in the dark alley, but he's searching for him under the light. Why? When asked, well, that's where I see. And so we're very biased for searching for answers where we can search and asking questions that we can solve. But the result of all of this is that it became clear that the basilar system is a cool system. It's kind of constrained. It has 2 inlets in blue, the vertebrals, 2 potential inlets, the PCOMs, and 3 targets, the basilars and the PCAs. And with hundreds of volunteer studies, we developed normative values of what the flow should be in these 3 targets. And we came up with an algorithm to dictate treatment for those patients. We published that for the first time in Stroke in 2005, and then CEPI took it to the whole nother level with the Veritas study, which was published later, and clearly demonstrated that low flow status in this system is a harbinger of increased repeated stroke risk. So based on that, we can stratify management, and there's a lot we can do surgically. I will show you surgical cases. A lot we can do. Really need surgeries in the VB system. So starting from the bottom and working our way up, here's a man that comes in with strokes, pons, cerebellum, occipital lobes. He has one vertebral that's occluded and the other one that's greatly stenosed. So vertebral artery origin stenosis. The flow is reduced according to the algorithm in these 3 vessels, basilar below 120, PCAs below 40, and you see on the right side, he's getting something from the PCOM. The options are multiple, but the best one is the vertebral to carotid transposition. And the key points here is that the vertebral artery will then lay in the V1 segment in the triangle between usually the transverse process of C6 and the longus colli and the scalenus anterior. You see the carotid and the jugular, the vagus. You have to mind the sympathetic chain, and on the left side, of course, the thoracic duct. The anastomosis is tricky because it's on the back side of the carotid. So you need to have enough length of the vertebral artery, and you need to rotate the carotid when you do the anastomosis so that when you finish, it flips back into place. So here's such an example of this bypass, and the vertebral artery is isolated. The flow is measured. It's low at 15. The vertebral is then cut, and then it's rotated. The carotid is rotated, and anastomosis is performed on the back side of it. Here's the anastomosis being performed. And here is the end result after removing the clips. You see the vagus. The flow now has more than tripled in the vertebral artery, vagus bypass, and here's the thoracic duct right here, the thoracic. And here's the postoperative angiogram, which documents very good angiographic result, and the flows improved. Here's another one that we did a couple of months ago. Comes in with similar presentation, one vertebral gone, the other one stenosed, large stroke. We took him, and here's this picture. I want to show it to you again and again and again. So you have this carotid that fills the top of the basilar, and on the angiogram, it oscillates back and forth. Is this enough or not? But clearly, if you measure flow, it is not enough. And not only is it not enough, looking at the flow in the mid-basilar, look at this, what we call now an ominous waveform. The flow is only 4 cc's and is oscillating across a 0 line. That's this really bad setup for bad stuff to happen. So VCT, vertebral carotid transposition, but there was a slight complicated factor here. This man, I don't know what he did in life before, but he was the most muscular neck I've ever seen. Look at this sternocleidomastoid. Even after cutting the sternal head, the clavicular head, the sternal head was humongous. Look at that, retracted with a sponge. And once I expose, here's the vertebral at the bottom. You can't tell it because it's not 3D, but maybe you can. It's extremely deep, and there's not enough length to pull this vertebral all the way to this carotid. And I was not set up for anything else. I did not have the leg prepped. I don't have the arm exposed. I didn't think about it. I just thought, like usual, we'll swing it up and everything is good. And thank goodness for great fellows. So we're gonna call this now the Matt Koch contribution to this procedure. So Matt said, hey, look at that vein down there, the vertebral vein. And the vein actually exists. It's a really well-defined vein until you go to the V2 segment. He says, why don't you use that? I says, well, I never thought about it. Why not? So here's the vein, it's being marked, pulled it up, actually not bad. It's a 4 millimeter vein. And we measure the flow, and the vertebral is very low, it's 40. And here's the graft from the carotid, the little vein, to the vertebral, and it looked great and actually worked great. So the flow went from 40 to 124. And here's the angiogram, carotid, vein, vert. And more importantly, look what happened to the waveform. Remember how it was oscillating around 0? Look at it now. The minimum is 43. The top is truncated. So it's a antegrade flow. And the guy did very well. He had some GI complication, but today the guy is doing fantastic. So what else can we use this for? Here's a tandem stenosis. The origin is affected, low flow state, but there's also a distal stenosis at V3. So what did we do? We need to treat the distal lesion, but the axis is a problem. And the way to fix that is to do a carotid transposition, vertebral transposition to the carotid. And then through that, the endovascular option, kind of like what Dan showed, combining our work with endovascular. It's great teamwork and worked out very well. Now we move up to V2. The pathologies there are mostly compressive. So they could be tumor, they could be osteophytes, they could be other things like that. So here's the treatment usually is unroofing the compression. So this is a recent case, just a month or two ago. This guy, a few months ago actually, this guy comes in, stroke, and whenever he turns his head to the right side, he gets worse, he gets dizzy, and you can see his right vert, his left vert is compressed, and when he turns his head, it occludes. So that's a setup for embolism. And you can see why it's compressed. You see this massive osteophyte here. It's not a low flow state. The flow in his basilar and PCA are good. So we put him on medical therapy, aspirin and clopidogrel, and we thought it's embolic, he'll be fine. But he kept having recurring symptoms. So we had no choice but to go ahead with the aim of decompressing this stenosis to prevent it from embolizing anymore. If it doesn't work, a coronary bypass. You see the setup with the radiolucent frame. Here's Matt, here's Mani Bebahani, and here's the operative setup. And here's the exposure, lateral exposure, medial to the sternoclinoid, lateral to the jugular. And here you have to, of course, mind the sympathetic chain. And here's the picture. You see the vert after it's been decompressed. There's still this huge gnarly osteophyte. The flow is very low, and look how close it is to the 0 line. And then drilling it, and after decompress, it went from 3 to 67. And here's the angio, looks good. Not perfect, but good enough. And here's the vertebral artery. He did great. He went home a couple of days later. This is really cool case. Someone who has radiculopathy. She's a violinist. She has radiculopathy, and that's affecting her. That's her right arm. She had an MRI, and people didn't understand, didn't see any disc or anything like that. But you can see the problem. It's very interesting. She has this curly, cued, corkscrew vertebral artery that's stuck, jammed in her foramen and causing the radiculopathy. So the approach is the same. And once again, you see the sympathetic chain. You see the vertebral artery that's been unroofed. And here's the result. This is before, this is after. It's moved away from the nerve root, and her symptoms improved. And we published that. So this is pre-op, and this is post-op. So the Carney, you've heard about this. What is the Carney bypass? Dr. Carney is now an elderly, retired cardiothoracic surgeon. I had the privilege to know him. Great man. He taught me how to do this. He did it when they didn't even have nylon stitches. They would use silk sutures, if you can believe it. So that's the approach. And once you do this approach, you can expose the vertebral artery at C1, C2 through a anterolateral approach. And you can also expose the carotid. So here's the common carotid. And then once that is done, work cephalad, and by feel, you can feel the tubercle of C1. That's the accessory nerve, 11. And then here's the anatomy. So the bottom is to the left. You see the jugular and the carotid. Follow the ansa to the hypoclossal. The internal carotid is up there. The occipital is moving backwards. A landmark is the accessory and the levator scapulae. So the levator scapulae is going to cover the C1, C2 junction. And by removing that, you can then see C1, you can see the vertebral artery at C1, C2, as you will see here in a minute. So here's the vertebral artery at C1, C2, and you can decide what to do with it. So here's an example of a case where we used it. This man, every time he backs out of the garage to turn his head to the right, he'd have a syncope. So he cannot turn his head to the right. And what you see is multi-staged compression of his right vertebral. He did not have a left vertebral. And he also happened to have a stenosis of the origin of his internal and external, which was asymptomatic. So in this case, a Carney procedure was performed. You see the graft from the common to C1, C2, together with a carotid internal and external endarterectomy. And here's the angiographic result. Here's the graft from the common to the vertebral at C1, C2, and the carotid, which has been resolved. Here's another example where we use the Carney creatively, I would say. A man with tandem stenosis, vertebral and distal, treated, the stenosis distally was treated with an angioplasty with a good improvement of his flow from 89 to 157. But then the flow drops again. And that was because the proximal vertebral occluded. So how are we going to do this? How are we going to retreat it? Well, this is where the Carney procedure came along. So we placed the conduit from the common to C1, C2, through which the endovascular team reopened the stenosis. Again, tandem work. I will just glance over the occipital-pica bypass because you know all of this. And I would say it's very rare to use this procedure for ischemia. It's almost an oxymoron because there are usually a lot of collaterals between the occipital and the external. But to the top of the carotid, to the vertebral, that can happen. So that's a PCA bypass. Now let's just show this case because that was a vein graft which replaced the entire flow of his VB system. There was no occlusion. It was a purely hemodynamic problem. And often you do an angiogram or an MR angiogram, you see nothing. And you wonder, how is this person alive? And they're usually alive through PL collaterals. You can see the PL collaterals, they're all retrograde and very, very low flow state. So these patients exist, they're rare and they exist. So a variant of that is to do a interposition graft from the STA to the PCA with a short vein graft, which provides modest flows from STA to PCA to vein graft. Modest flow, not necessarily to do it for everything. And you can see the angiogram here, STA vein graft, 74 cc's, but enough. And here's another patient where I did this interposition graft, and I'm showing it because once more, through repetition, I hope to show you again and again this ominous waveform. This man had every VBI symptom, yet never had a full stroke, but he was symptomatic with every symptom you can think of. So look at the oscillating flow in his basilar as measured with the quantitative MR. And after surgery, this abbreviated bypass, good flow, and more importantly, nowhere near the zero line. Now, of course, it's better to go pretemporal, not subtemporal, as done here with an STA to PCA bypass. And this is the last case that I always like to show of a man that came in practically locked in from vertebral basilar occlusion because he had bilateral vertebral occlusions. But he also happened to have a carotid stenosis. So he was sent to me for a posterior fossa bypass. He was alive because of those collaterals that I talked about. He has very tiny PCOM and he has a right carotid stenosis. So the flow is, of course, low, so he fits the low flow state. And I thought, why do a bypass? What if I open the carotid, and what if that helps him? So I did that. You see, it looks good angiographically, but did it help flow-wise? It sure did. Why? Because look at that. Now the PCOM has 145 cc's going through it, and that resolved the problem. So sometimes you don't need to do a posterior fossa bypass to fix posterior fossa ischemia. We've seen it now with multiple examples. So I'll conclude by saying what I was trying to say earlier. VB disease is a tremendous opportunity for neurosurgery. It really is the stepchild of cerebrovascular neurosurgery. And I think if we use this opportunity presented to us to analyze flow and to identify patients that need a procedure, document that they need it, and learn from what we do before and after, I think that's a great growth area for us, and it can be intellectually and practice-wise very rewarding.
Fadi, thank you so much. That was unbelievable. Particularly, not too many people see this kind of vertebrobasilar disease, and I'm sure the audience have tremendously benefited from your extensive experience. Wonderful. Thank you so much. Last but not least, I'll invite Mike Lawton to tell us what's new in bypass and where he is in his thinking about bypasses and where does he perhaps see the future in bypass surgery. Unmute yourself, Mike.
Okay, can you hear me, Jacques?
Yes.
And can you see my title slide?
Yes, indeed. Great.
Excellent. Well, Jacques, thank you for the invitation. As many of you know, before the pandemic, Jacques had been making a second career as being sort of the organizer of multiple master neurosurgeon retirement symposium. And so whenever I get an invitation to speak from Jacques, I have to wonder, am I done? Am I being told that it's time for me to retire here? But thankfully, I'm not the oldest person on this panel, so I don't think that's my curtain call. And so, Jacques, I want to thank you. I also want to congratulate you for continuing this symposium, which I think is obviously incredibly valuable to the residents and young neurosurgeons around the world. So with that, what I thought I would do is focus on innovations in bypass surgery and try and show bypasses that you haven't seen from the previous speakers. You've seen many, if not most of what I could possibly share with you. So what I would what I'm going to try and do in this talk is to just show you 3 cases, no more than that, just to talk about innovation and talk about some themes. So I'm going to share with you, first of all, a case of an intracranial bypass. I'm then going to share with you an example of a 4th generation bypass. And lastly, I'm going to show you a novel application of bypass technique in what I call the binder ring bypass. So when I think about bypass, my thoughts are pretty well laid out in my book, 7 Bypasses. But in this table, if you think about the 7 categories of bypasses, what I try to do in my practice to be innovative is to push myself down this table into what I would call the 3rd generation bypasses, the ones that you see in the top of the red box, the reimplantations, the in situ bypasses, the reanastomoses, and the intracranial to intracranial bypasses. These, I think, are the more novel bypasses, the ones that you're not typically used to seeing or doing. The 1st and 2nd generations are the ECIC bypasses with scalp arteries, or the ECIC interpositional bypasses that Fatty just showed. So these 3rd generation bypasses in this next group of 4 are the what I would call that next generation. And the 7th category is a combination bypass, which is any bypass that brings in multiple different bypasses. And so this first case is an example of this 7th category, this combination intracranial to intracranial bypass. And I'm going to show or demonstrate its use in this case. It's a giant thrombotic ACOM aneurysm, like what Dan was talking about. And a little bit different approach, though. So you can see the MR appearance here. It really occupies the region from the ACOM complex all the way up to into the ventricular system. And here you can see angiographically how it's only a small luminal component, whereas the vast majority is thrombotic. The procedure that we're going to do, I've got a nice little animation here. It's going to be what I call a squeeze play. And by that, I mean, we're going to combine a pterional craniotomy, which you see here, in the same incision as this bifrontal craniotomy. So it'll allow us to do basically 2 bypasses in one. And that's our combination bypass. So up at the top, you'll see the code. I spent 20 years just north of Silicon Valley, where a lot of my friends and colleagues were computer scientists. And so this whole idea of coding bypasses is really intriguing. And I'm going to come back to this at the end and finish with this idea. But I do think that we need to be more precise in our language, and we need a way to express these innovations that we're putting forward here. And below the code is a schematic. The schematic here shows you the bypass that I'm going to do in this case. It's a triple bypass. We've got a interposition graft that's going to go from the M2 over to the A2, and that's an IC, obviously. And then we've got an in situ A3 to A3 bypass in the interhemispheric fissure. And that will essentially do this. We're deconstructing the ACOM anatomy and reconstructing it at the same time. So if you think about the normal anatomy in this first column, you've got the injection of flow into the ACA territory with the A1. You've got communication from left to right or right to left through the ACOM. And then you've got 2 outflows. And so in order to take down this anatomy and deconstruct the aneurysm, you've got to rebuild each element here. You've got to first think about the inflow, and that's going to be our M2 to A2 interposition bypass. You've got to think about a communication from left to right, and that's going to be our A3 in situ bypass. And you've got to make sure that the outflow can redistribute itself to the entire ACA territories on both sides. So here now is the case. What you're seeing is one of 2 exposures, the Sylvian exposure. This is now the interhemispheric exposure, and you want both of those to be in play so that you can get to both areas for the bypass. This first window here now just shows you the view looking down the interhemispheric fissure. It's at the A3 segments. You can see the stage that we built is right above the corpus callosum. And as you've heard the prior speakers talk about, this is a perfect setting here for these in situ bypasses because the arteries are in parallel with one another. They come together beautifully and they construct or reconstruct that communication from left to right. So really nothing new here. This is just your standard A3 to A3 bypass, but this is really a precondition for the work we're going to do. This is that communication rebuild. We've basically taken the ACOM and moved it distal to the aneurysm downstream. So now with that in place, what you're seeing here is the view subfrontally. You've got Huebner here, you've got A1 over here, you've got A2 here, and you've got just a little corner of this thrombotic giant aneurysm here. And so you can see that the A2 provides us with a very nice landing zone for our interpositional bypass. We can make an arteriotomy here linearly, and this is a really nice thick recipient for our radial artery graft. So you can see our fish mouth graft here going down. It's going to be an end to side anastomosis to the A2. And I always show from deep to superficial. You always want to do the hardest thing first. And so running continuous technique, I'm a real fan, having learned that from Dr. Spetzler. I think it's a time saver, and it's also a nice way to seal the vessels really seamlessly throughout the run of sutures. Here's the second suture line here going now on the other side of the A2. And this is going to be our recipient. And so we've got that taken care of. Now we run the end of the graft up to the Sylvian fissure. This is our M2 artery, provides us with a very nice donor site right off of the M1 trunk. And you'll notice here I'm using an in situ technique, even though this is an end to side anastomosis. And the reason is it allows me to really shorten up that graft. I can see right down the barrel of both lumens. And it's not unlike that A3 to A3 I showed you, where the stitch work is all interluminal. And now, as we finish that one, we can run the suture line now across or down the other side to complete the anastomosis. So this now is the donor, the M2 donor. We've got our A2 recipient. We've got our A3 to A3 bypass. And this has basically rebuilt our ACA circuit. We've got an entirely new anterior cerebral artery circuit built that we can now open. So here we've got our interposition graft. This is our injection into the ACA territory. We've got our A3 bypass, which is our communication left to right. And with that, we can now return to our aneurysm, and we're going to do not a complete trapping. The reason being, you've got this vessel right here. This is Huebner. If we were to completely trap the aneurysm, we would trap perforators and the recurrent arteries here within our trapping clips. So we're limited in our trapping, but we're going to do a proximal occlusion, a distal occlusion, and that's going to essentially reroute flow all the way around the circuit from the M2 to the A3, across our bypass and the round. And the reason we know that circuit is working is if you look right in here, we're going to see recurrent artery of Huebner here that fills. So you see good flow in the recurrent artery. That tells us that the flow in that circuit is going all the way around the horn and coming out the bottom between our trapping clips. So this completes our bypass. Here's a nice overview. And it again shows you how much you can accomplish through that squeeze play. Here is the postoperative angiogram. The interposition graft is shown in purple. The A3 bypass is shown at the arrow. And you can see this nice rebuild of that circulation. I think it's a good example of a couple of things. This is some numbers on my giant aneurysm experience. If I look at the numbers of bypasses that I've done for the giants, it's 44%. And it just brings home this point that giant aneurysms are a completely different entity. They're not just large aneurysms that can be clipped. They require a completely different strategy, and that strategy is bypass. Second case. This case will demonstrate the 4th generation bypass. And you had a little preview of that on the last one, because that last anastomosis that I showed you was a type 4A bypass, meaning that it was a conventional construct, but it was created with an unconventional suturing technique. In other words, the in situ technique. So by sewing intraluminally, like you would for an in situ bypass, you are moving a standard end to side anastomosis into this realm of a 4th generation bypass or a type 4A. You can also do a type 4 or a 4th generation bypass as a type 4B, which is an unconventional construct created with a conventional or an unconventional technique. And that's what I'm going to show you in this next case. This next case is a middle communicating artery. And before I show you that, what going to the 4th generation does for you is it takes these 7 categories that you should now be familiar with as the 7 bypasses, and it creates these new opportunities or new types of anastomoses that you wouldn't otherwise have had available to you if you had stuck to the standard conventional techniques or the standard conventional constructs. And so you can see in this table that there's no longer just one example of a 3rd generation or a 3rd type of reimplantation. You have all of these additional types of reimplantation, whether it be a 4A or these 2 4Bs. So let me show you a case example, because I think an example speaks 1,000 words. This is an example of reimplantation. These illustrations are nice and clean. They show you a reimplantation of the M2 onto this other M2 with an STA as a donor. And that's your conventional end-to-side anastomosis. Now, if you do that anastomosis with an intraluminal suture line, you can see that that becomes a 4A. Or if you look over here to the right, if you do that reimplantation instead of with an end-to-side, but with a side-to-side, or here with an end-to-end reimplantation here, that becomes a 4B. So you can see that you can expand your repertoire if you begin to think in this 4th generation concept. So here's the middle communicating artery, and I'm showing you this one here. It's a relatively simple one. It's just a double barrel MCA bypass here with the STAs going to each of 2 recipient trunks that come out of this dolichoectatic aneurysm. And this is done as a precursor. And you could say, well, you've done all you need to do with just that. But you'll see in this case, these outflow vessels were quite large. I wasn't sure that these small STAs were going to be sufficient. And by doing this step here, this middle communication here, you allow the grafts to then redistribute the flow as called for by the demand. And so you're letting the demand govern the flow. So these are just the STA MCA bypass portions of the case. You can see there's nothing particularly fancy here, but I want you to notice how small the STA is relative to how large the recipient M2s are. And so that mismatch was of some concern. And here's the first bypass in place. The second bypass is over here. This is now the trapping of the aneurysm. The outflow vessels are closed. You see both STA double barrel bypasses are open. Now we go on with our proximal trapping clips. And here now is the MCOM creation. So we're creating a middle communication artery, like an ACOM or a PCOM, by sewing the 2 dead end stumps of the M2s together. And that creates this communication channel. Here you'll notice this is a type 4A anastomosis. I'm inside the lumen. I'm inside with my suturing, and I'm bringing these together in that fashion. But this anastomosis is a type 4B construct because you're doing a reimplantation with an end-to-end anastomosis. So it's an unconventional construct using an unconventional suturing technique to create this middle communication between the M2 trunks. And here is the icy green showing that connection. You can see the reconstruction here. And this flow reconstruction was perfect. This lady did extremely well. And you can see that the flow is governed by the demand, not by how you've actually wired your bypass. So moving on, the third example of innovation is this one. And this is not necessarily a new bypass either. It's just using bypass in a novel application. And let me preface this story by just talking about what I've come to refer to as macrovascular decompression. We're all familiar with microvascular decompression. We do it for hemifacial spasm. We do it for trigeminal neuralgia. And we simply move these arteries off of the nerves to relieve the compression. Well, that works fine for an ICA or a SCA. It doesn't work so well when you've got dolichoectatic vertebrobasilar pathology. And for those, you need something more. You need a macrovascular decompression technique that will move this massive artery. And so this paper, I think, is important for those who are interested in this concept, because when we approach a lot of these, we approach it from laterally from the side, and our instinct is just to pull it over. But in fact, that's pulling the artery in the wrong direction. You actually have to pull the artery forward and medially, not laterally and posteriorly, which is the direction you would pull it if you just slung it from a retrosigmoid approach. And so you need a different kind of pull. You need a pull that is directed anteriorly. And this this illustration, I think, nicely demonstrates the technique that I've come to be very fond of. In more detail, what I do is I make a little sling of or strip of Gore-Tex. I too, like Dan, learned this from Robert. Gore-Tex is really a phenomenal material for this. It's much better than muslin, which is what I was using in San Francisco. But if you make a little slit in one end and a taper on the other, you can create this lasso that slings the artery, and then you only have one tail to deal with. You only have that single tail to affix to the clival dura. On this illustration on the right, what you see is the clival dura being punctured with a 19 gauge needle. And what that does, it just makes a little entry into the epidural space of the clivus. And with that epidural access, you can basically now feed one blade of this aneurysm clip into the clival epidural space. You can pull that single tail of your sling through the blades of the clip. And when you release the clip, you can then pull the tail through, you can adjust the tension, and you can gradually mobilize that artery forward. And at the end of that maneuver, you can see how the artery is pulled both anteriorly and medially to the clivus. So what does that have to do with bypass? Well, nothing really, until we get to this case. So I've been doing that technique for these cases and having some good success with that. But what do you do in this case? This is an example of a gentleman with so much redundant artery here that even if you sling it in the way that I just showed you, you're not going to relieve the brainstem compression. There's just simply too much artery in the way. And this guy presented with compression of his seventh nerve and hemifacial spasm, terrible spasm, and vertigo and dizziness. And so you can see, looking at the pathology here, there's just too much artery to do our normal sling. So what we're going to do here is what I call the binder ring bypass. The idea here is we want to transect the artery, open it almost like we do a binder ring on a notebook, and then we're going to reroute the artery around the nerves so that instead of being under and medial and pushing on the nerve, they're going to be over and lateral and around the nerve. And by then reanastomosing the artery end to end, we've then reconstructed the artery and repaired our intervention. So here's an example, an animation showing this dolichoectatic process, this bending of the artery laterally, this intersection with the nerves, which is the genesis of the symptomatology. The idea here with our technique is then to trap the artery, do a transection and a reanastomosis end to end. You see how the artery now routes lateral to the nerves. It doesn't matter going forward how this artery degenerates and expands. It's now lateral to the nerves. There's no contact, there's no nerve compression, and we've alleviated the pathology. So here is the operative video. You're looking here at the 7th and 8th nerve bundle here. The lower cranial nerves were down low. And this you can see is this loop of artery, which we have to mobilize. Now, one of the unique things about this case was that this was all V4 segment. So we can trap the V4 ipsilaterally, and there's still flow in the contralateral vert. Even though it was small, it provides us with some basilar flow during this anastomosis. But you can see now how we can transect the V4, this dominant V4. We can reroute the artery over the 7th and 8th nerve bundle. The nerves are now relieved of their compression. This is now an end-to-end reanastomosis. And again, going back to our 4th generation concepts, you're going to see that I'm going to sew this intraluminally. So this is a type 4A construct. So my suture work is intraluminal for this deep wall. This now is the more superficial wall. And once again, the running continuous suture technique is really nice. This is a 9/0 suture with vessels that big. You need a nice beefy needle. But you can see that now the artery is repaired. It's back to its baseline. It's rerouted lateral to the cranial nerves where the patient was symptomatic. And now we can restore the flow by coming off with our clips. And meanwhile, that contralateral vert took care of the posterior circulation flow during this time period. There's just a view of the VBJ. There's a view of the reconstruction. And you see now, all through a simple retrosigmoid approach and no retractor. So here is the postoperative films. They look the same as they did preoperatively, but the difference is that we've rerouted the artery completely. So those are the 3 cases. I think they demonstrate some important concepts and innovations at the same time. And I want to just finish with this, something to leave you with. You know, if we're going to innovate and if we're going to do these really complicated bypasses that I've shown you and that Fatty has shown you and that Dan has shown you, we need to be better, not only in describing them symbolically or schematically, but also in our nomenclature. And so this is all from 7 bypasses. These are the symbols, the system of symbols that we've used to describe all of these. This is a program that will soon be available on the Barrow Neuro website. You can basically go click on your graft, you can lay in your graft, you can then choose your anastomosis, and you know, you can put the anastomosis that corresponds to how you're going to stitch this in, and it's just a drop and drag, or click and drag. You can then essentially build these schematics, and not only as you can you build a schematic, but it's telling you the code as you build it. And this code is important because this is where I think we get precision in our descriptions. The case that I showed you, you might have a hard time describing that in a note or in a communication on a paper or to a colleague. But if you adopt this code, it's all there, and it becomes a very nice way to express the nuances of the technique. And let me just expound on that a little bit. I think the first thing that we needed to do to get a code was to finish Roten's segmental anatomy nomenclature. And this is one of the few papers I ended up working on with Dr. Roten. But we finished off the alphanumerics here by putting together the code for the cerebellar arteries. And so now there's an alphanumeric for every segmental address that you can possibly imagine. And so that's important. That tells you the segments that you're going to be using. And to construct your code, the key is having a side element, a left or a right, specifying your arterial segment or your donor artery with those alphanumerics that I just mentioned. The key is this bracket. The bracket now introduces how you're bringing your vessels together. It's not just an STA-MCA bypass, but instead of the hyphen, we have the donor arteriotomy, we have the recipient arteriotomy, and you can even put the technique as a superscript, whether you use interrupted, continuous, or intraluminal suture, which will designate for your reader whether this was a type 4A or a type 4 whatever. And then on the other side of the parenthesis is the symbols or the alphanumerics for your recipient, both side, segment, and recipient artery. And you can see some of the abbreviations that are used here. And so if you adopt this code, you can take a very complex schematic, which is drawn out here with our schematic program, and you can reduce it to code. And if I were to just give a resident this little strip of paper that says this, that resident should know exactly what to do in the operating room. He or she will know to harvest a saphenous vein graft, to prepare the A1 as our donor site. It's going to be a side to end anastomosis. And on the other end, you're going to have a double reimplantation technique here with the side-to-side reimplantation for your first M2 and an end-to-side reimplantation for your second. For these middle communicating arteries, which I've been talking about, here's that one I showed you, the 2 double barrel STMCA bypasses, the end-to-end reanastomosis here. And here's our schematic. And here we can construct the code. You can see the donor A1, the elements of the first anastomosis. Here's our radial artery graph, elements of the second anastomosis. And here is our end-to-end middle communicating artery bypass here. So I think this code is very useful, and I hope that you'll read our upcoming publication on this and think about using it. So this is my last slide. The title of this talk was about, or this symposium was about mastering aneurysm surgery. And this is my short list of things that I think go into mastery. You have some true masters on this panel. I certainly have learned most of what I know from Dr. Spetzler and tons from Dan and Fatty and certainly Jacques as well. But for my own take on this, this theme, I think these are the 6 things that I would pass along to the audience. And they are first and foremost the microscope. You've got to be so comfortable with that microscope that it's really an extension of your eyes and your body. You have to become one with it, which means using the mouthpiece, sitting down when you operate, getting your hands and your arms comfortable, and spending a lot of hours getting familiar with every feature of that piece of equipment. Dexterity goes without saying. I think time in the lab, time spent analyzing your hand motions, your hand positions, everything about how you touch instruments and how you handle tissues. That's really what dexterity is about. You can't be a master without really understanding anatomy and pathology. The more you see of both, the better. Case volume. I think the secret to most of the masters that I know, secret to their success is that they love to operate. They can't get enough of it. And case volume is what propels them to that highest level. I would put in this plug for synthesis. And by that, I mean, you've got to spend time thinking about what you've done, looking at your results, looking at your outcomes. And I think that synthesis in the form of writing forces you to really collect your thoughts and to push boundaries further. And that's the final thing. Pushing boundaries is really important. You don't get to be better unless you push yourself beyond your comfort zone. And I certainly learned that from my mentors. And I think if you push yourself and you do some of these ridiculous bypasses that I'm showing you, I'm not trying to get everybody to go off and do bindering bypasses, but I think the lesson here is that you've got to push yourself. And if you push yourself within your own space, however that is, that's how you'll grow as a surgeon. That's how you'll continue your journey to mastery. And I think for all of us, it's how our specialty will improve. So Jacques, I'm going to stop there. Once again, my thanks for including me on this.
Fantastic, Mike. Beautiful, beautiful presentation as always. Are you going to make the people who use the exoscope upset by not including the exoscope in your prediction of innovations? And why don't you say a word about what you feel about the exoscope in general, replacing the microscope?
Yeah, it's a good point. You know, there's really, there's nothing wrong with the exoscope. Whether you're using magnification and illumination by means of a microscope or an exoscope, really, they're interchangeable. Why I don't use the exoscope is because I can't connect with the exoscope with the mouthpiece like I can, excuse me, with the microscope. And to me, that's its fatal flaw. Until it can move with me, until it can become one with me the way that the microscope can, then I don't think it's at the same level.
I'm with you, and that's why I just wanted you to say what I thought, so that I thought you'd say that.
Jacques,
hey, Robert, glad you joined us.
It is, I mean, the point that Michael just brought up is very, very close to fruition. There is already a couple of systems that give you that same sort of connectivity to the microscope while still having the advantages of the exoscope. I mean, Mike likes the sitting position. I never have, because I just couldn't operate like this for very long without radiculopathy in both sides. When you have the exoscope, then that limitation really disappears. So I think there's a real future there. Can I make one more comment for
course.
Fadi? Because Fadi, I was really impressed with your presentation, and I fully agree that the vertebral artery transposition is one of the best operative procedures for revascularization. We published a case where 17 years later, it was full patency. But where you put in the little vein graft, another option of achieving exactly the same thing is just to release the vertebral artery from its bony confinement, going a little bit more superior, and you would have only had to do one anastomosis.
But who wants to do that? I mean, why do one if you can do two? Great point, though. You're absolutely right.
And any other quick comments between the four speakers to each other? If you don't, I'll ask Nick Khan, my current fellow, to show you guys one case and get your input, and then we'll address the audience questions. I'll manage that. Okay, Nick, go ahead and share your slides and do it efficiently. Nick has been a delight to have this year as my fellow, and Nick will be going back to University of Tennessee in Memphis, where he was a resident, to join them on the faculty and be the rising star that I know he will be.
Thank you, Dr. Morcos. Amazing talks. I've learned something from everybody that presented this evening. I'm Nicholas Kahn, the current fellow, Dr. Morcos at the University of Miami this year. And I chose a case to share with the expert panelists that has many different ways to manage, so I'd like to get their opinion on it. So we'll just get started. So this is a 38-year-old man who presents with the worst headache of his life. He has no other relevant past medical history, and he's neurologically intact. His CT scan shows an area of hyperdensity near the right carotid cistern, and a CTA shows the irregularity of the right ICA. A formal cerebral angiogram is performed, which shows what we thought was a dorsal-medially pointing carotid blister aneurysm. We also see good cross-filling across the anterior communicating artery here. These are magnified oblique views, which show a wide base 4x2 millimeter carotid blister aneurysm, as well as the anatomy of the anterior choroidal and posterior communicating artery. This is a 3D reconstruction just to better understand the anatomy. So in summary, we have a 38-year-old who's Huntington Hess 1, Fisher 1, has no other medical comorbidities. He's neurologically intact and has a right dorsal medially pointing carotid blister aneurysm. So at this point, I'd like to stop and just open it up to the panel of experts and see how they would manage this.
Robert, may I invite you to unmute and give us your thoughts? You're muted. Robert, you're muted. Yeah.
I like to be unmuted because that's how Michael likes to have me as a participant. There's no question how I would treat this, and this is going back to the Gore-Tex. It's beautiful because you can put cuts in it for the anterior choroidal artery or PCOM if they have to. You wrap it around, put a little cotton on it, and then right angle clip, hold on to the two ends and snug it down. I think we've published that technique, and I think it's the one that really lasts the longest. And with that very thin Gore-Tex, it's so malleable that you really don't have to touch the aneurysm at all during that period of manipulation.
Dan, you concur? You showed some beautiful cases in your presentation.
Well, this is actually almost exactly like the case I showed, and I agree with Robert. And as I said in my talk, I give him credit for teaching me that technique. It works. It's so versatile, and like he said, you can cut unlike the Sunt clip graft, which comes in one size. The Gore-Tex is malleable, and you can cut a slit to accommodate posterior communicating anterior choroidal arteries and wrap it. In my institution, if I were away and that case came in, there are endovascular colleagues of mine that would treat that with flow diversion. And we've had some problems with dual antiplatelet therapy in patients with acute subarachnoid hemorrhage. So I mean, that's an option. But if in my hands, I'm very comfortable with that. And I've been very, very pleased with the Gore-Tex clip wrapping.
Fadi?
Absolutely. I think this has been well described by Robert and others, and Dan showed a beautiful example of this. What I would add is that what one's trying to do is compress the vessel enough to make it stop bleeding, but not enough so that the flow is impeded. And Dan showed a good example how the angiography at surgery, and he has a perfect setup for that as an institution. He's written about this for a long time, that can be done easily and quickly. The other way to do this, or complementary to do this, of course, is to check flow. And I've seen many examples where, as exactly what Dan showed, just a little bit, going from a 3.5 millimeter, say, Sundke's clip to a 4 millimeter Sundke's clip, and the same would be true for a sling, will change the flow, will almost double the flow. So measuring flow would be a very useful adjunct in these cases.
Mike?
Yeah, I don't have much to add from the prior speakers. I would say this, there's a difference between a blister aneurysm and a dissection that's essentially just a hole in the artery with some clot over the top. If this is a true blister, then I think the Gore-Tex sling is nice because there's actually an aneurysm sac there to apply the clip to. On the other hand, if it's a dissection and this is a pseudoaneurysm with just a clot over a hole in the artery, then I'm not sure that Gore-Tex sling is going to get you out of trouble. And I think you really need to be prepared going in for carotid replacement, which means a high flow bypass and a graft and exposure of the neck.
Okay.
Nick, if I could just add real quick, Jacques, something to Mike's point that I completely agree with it. In fact, there was 2 of these cases that were true pseudoaneurysms, and we took what looked like the aneurysm and we sent it to pathology. It was nothing but clot there, and we published that, and we call them pseudoaneurysms. So that's a very, very good point.
Nick, why don't you continue?
So this is what we did. So this is a right pterional craniotomy. We did dissect the STA and have it available. You can see the area of fibrin clot and the blister aneurysm and the optic nerve there. We did come lateral to the carotid in order to gain access to the anterior choroidal and the PCOM. That's what we're doing with the dissection here, where you can see the top of the basilar and the posterior clinoid. This is just further defining some of the anatomy and preparing for the size for a potential sling. In dissecting the posterior communicating artery and the anterior choroidal, we saw that the choroidal was a little bit distal. We measured flow in the M1 segment prior to temporary clipping, and this is us placing a temporary clip on the carotid. Then we're going to remeasure flow here in just a second. And this is just showing that the flow was 30 milliliters per minute pre and post temporary clipping, showing good flow through the ACOM. The cut flow on the STA that we dissected was 50, and we had it prepared for use if needed. With a temporary on, we're starting to try to define the neck just a little better so we can trap the area of the aneurysm, and carefully trying to make sure we don't include the anterior choroidal in our temporary. And once we start to dissect the area of the fibrin clot, we'll see that there's this white area on the side of the ICA, which looks to be abnormal. So we thought that we needed to exclude this diseased tissue from the circulation. So in order to do that, we thought that we had to basically exclude the carotid along this blue dotted line here while keeping the anterior choroidal patent. And we thought that a Gore-Tex sling could be used, but just like the other experts said, that we have to cut a slit into it. And we thought that with the flow measurements, it gave us extra confidence that we could trap this segment. This is what we did here. Of note, we did have MEPs and SSCPs that were run several times throughout this process, which remained stable. So this is placing the trapping clip and removing, this is putting a mini clip on the posterior communicating artery to show that there's no flow coming back to that. Removing the initial clip here. I'll fast forward just a little bit through this. This is ICG green showing that the anterior choroidal was patent. And the patient did well postoperatively. He remained in the hospital for his post-subarachnoid care, remained neurologically intact. This is a CTA showing good cross-flow across the ACOM, then the clips for the trapping that we had placed. And a postoperative angiogram showing that the anterior choroidal was patent. And here's a couple pictures from some of other Dr. Morcos's cases, just showing examples of stunt clips and wraps here. So I'd like to open it back up to the panel of experts. Any comments on things that you may have done differently or suggestions?
Okay, good.
I think it's a reasonable solution. My concern about sacrificing a carotid artery, I think it's never a good idea. You've had a subarachnoid hemorrhage, so I don't know exactly where you are in the phase of maximum spasm or the risk of maximum spasm, and that loss of that artery might cause you trouble that could have been avoided.
Yeah, you're right, Robert. I would have never done it if it was a large hemorrhage. It was a very focal clot, and I too, of course, had the trepidation. But I really did try. I want to do the sling, which this is a picture of most of the cases. I do exactly what you taught. There was no good way to slit the Gore-Tex, I thought, and save the choroidal and go distal enough to the ICA bifurcation. That's why I felt it was necessary to trap it in an angled way. Luckily, he didn't go into vasospasm. That would have been a disaster with the loss of the carotid artery. I just wanted to infuse that, little variation on doing it. And yeah, these stunt clips are exactly like Dan said there. They tie your hands. You don't have a continuous control of the situation. It's just saccadic sizes.
I would just add that I've had two cases where I've sacrificed a carotid. I've had good flow measurements, angiographic confirmation of ACOM flow. Patients have then gone into spasm a week later, and they've become symptomatic. And then you're really in a bad way because you're bypassing at that point in a patient with spasm in a swollen brain at the worst possible time.
Yeah, agree. Nick, did you have something else to show? No.
Yes, sir.
That's it. Yeah. I mean, if you read the literature now, our endovascular colleagues will show you meta-analyses supposedly showing superiority to flow diversion over microsurgical treatment, and it might be certainly biased series where you had to deal with severe hemorrhages, but that notion out there that endovascular is better than microsurgical for blisters is certainly there among our colleagues mostly. Okay, if it's okay with everybody, let me go through some of the Q&As that have come in. I'll select some. I'll start with you, Robert. People, of course, enjoyed your pre-recorded presentation. From Satya Palapotula, when removing the AVM and fistula, do you cauterize and mainly cut the vessels that go into the spinal cord? For large AVM, should embolization be the first treatment option? If so, why? I guess it's a double question for you, Robert.
I think it's pretty straightforward. In the old days, I remember saying that you never use the bipolar in the brainstem or in the spinal cord. Naturally, that's all nonsense, because what you really have to do is you've got to get hemostasis. So using low power with irrigation, I used bipolar all the time. I think importance is that it's a non-stick bipolar, so we don't pull out the vessels. And I find embolization very useful because not only does it diminish flow through certain vessels, but it really tells you where you are based on the roadmap that the Onyx provides.
Another question.
Is there any particular non-stick bipolar you prefer?
That's a very good question. And Dan, I assume that behind you is one of your patients
Yes,
on the wall. Enough said.
they didn't pay their bill.
Yeah.
Okay, Robert, what factors determine whether Conus AVMs can be managed surgically or endovascularly? Or do they all require multimodal treatment?
In my hands, they all required multimodal treatment. The real secret naturally is to have an endovascular partner that knows what the surgeon is capable of and vice versa. So when there is an additional risk by being too aggressive with embolization, don't do it.
Yeah. And do you have any sense why AVM specifically love to develop in the conus region? I guess, is it just the basket arrangement from embryology?
Right. I think that's exactly right. I think it's really that unique basket architecture, the angio architecture, that defines why they're there.
The next question I don't fully understand, but I'm going to read it from Dr. Rana. Is there any possibility of having normal vasculature of the spinal cord after using onyx during pre-op embolization? Maybe he's asking, is it possible to preserve normal spinal cord vascularity?
The answer is absolutely yes.
Yeah.
And that's the job of the endovascular, a specialist.
Yeah, exactly. Dan, on to you now. What are, from Dr. Satya Palapotula, what are certain factors that you need to take into consideration for choosing vessels for bypass when trying to reduce pressure in the aneurysm? I guess, how do you select your conduit? And how do you think about it?
The factors that influence that is the location of the aneurysm and what your strategy is in getting rid of it. I showed 2 examples of middle cerebral artery aneurysms, one in which I chose to do a distal occlusion and create a blind sac, and another one where I chose to do a proximal occlusion. And it was the things that go into those decisions. The decision to use a radial artery was that I was replacing the entire carotid circulation, number one. So I thought I needed more flow, although a double barrel superficial temporal artery can work. The decision about whether to do a distal bypass, a distal occlusion or proximal, I think really depends on the anatomy of the lesion you're dealing with. And the one where I did a distal occlusion, I was very concerned about filling the lenticulostriates directly. And I really was confident that aneurysm was so thrombosed the blind sac would occlude. In the second case, I wanted to reverse flow in what I thought was a dissection, but because of the vasospasm that it was existing intraoperatively, we delayed that, but then did an endovascular proximal occlusion, if you will. So I hope that answers the question. I mean, the decision is complicated. I think Mike addressed it very eloquently in his talk, where he talks about all kinds of different bypass techniques and how you can choose those and be very creative as he's been.
Mike, a question to you from Dr. Muhammad Asfour. I think you need to explain why you did not use simply a piece of Teflon for these large vessels. That's what he's asking.
Yeah. So when you've got a macrovascular decompression syndrome where it's an enormous artery, it's just simply spitting in the wind. And Teflon just doesn't provide you with the kind of relief that you get with a small vessel compression. So I've tried it. I remember early in my career thinking if I just add more padding here, it might actually relieve things, but it was completely useless. I think what you've got to do instead is you've got to, unlike the small vessels, you really got to force that artery off of the nerve and move it to a new spot.
Mike, by the way, on a side note, I had a paper published with a similar thing on sling and I used the word macro decompression. One of the reviewers chastised me for using that. He said the word micro decompression doesn't relate to the vessel wall. It relates to the fact that you're using a microscope. And I thought, well, who said? I don't know. Is that true? He said, well, I mean, he's got a point. I must say, the SCA and the ICAs are not microvessels. I've used the same term as you are, but he's actually correct. You know what I'm saying?
Yeah, Jacques, you remind me of when we first published the AVM grading system, and the reviewers got hung up on the word eloquent. And they didn't accept the word eloquent until I showed them an article where Drake had used the word eloquent to define that portion of the brain that we also define. But get used to that sort of stuff. That's why we have reviewers.
That's right.
Yeah, I think
I've actually published also using the word macrovascular decompression for the same same entity, and I think it is perfectly appropriate. I think it refers to the size of the vessel, and it is a totally different entity. I agree with Mike. If you put a bunch of Teflon in that case, it's just going to compress the seventh nerve or glossopharyngeal, whatever nerve you're trying to decompress, or the brainstem oftentimes is compressed as well, and you've got to move the artery in those cases, I think.
Yeah.
Well, Jacques, maybe what we just need to do is pull the microscope out of the field for just a second and view the field macroscopically with our own eyes, and then we can call it that.
Exactly. You're right.
Use an exoscope.
Exoscope, yeah.
Guess where it is.
Fadi, greetings from Mohammed Helmi from Egypt. He'd like to ask you, from the hemodynamic point of view, do you think fish mouthing the donor artery in ECIC bypass affect the blood flow?
Well, it depends on how big the vessel is. From purely hemodynamic, if a vessel is 2 millimeter or greater, the donor, I mean the conduit, in the ranges of flow we're talking about, which is probably no more than 200, it's not going to make much difference. On the other hand, if you have a vessel less than 2 millimeters, it will make a difference.
Fadi, isn't an additional point that the fish mouthing also changes the angle of the two vessels, and almost uniformly it increases the likelihood of the whole flow because they're in more concert.
You're absolutely right. A lot of work has been done on that, and that's been that's absolutely correct.
Jacques, I'm surprised that you're sitting so quietly in your chair when you have an opportunity to discuss the mathematics of the anastomotic area here.
I wait till I have a very erudite panel. I'm not going to waste my talent on you guys, so I'll do it another time. 2 questions for Mike from Dr. Ayman Al-Shaiji. How sure are we to know that the rerouted vertebral artery is not going to compress the nerves from above? Well, I think your beautiful video is, I'll answer for you. I mean, it's very clear. You've cleared the obstacle and there is lots of space above it. Second question is, why connect? Yeah, I agree with him. He's asking you, why connect the M2 together? He's talking about your middle communicating artery. How does that help? Why it's not enough just the double barrel? And if I could add to his question, if you measure the flow, I guess like Fadi or I routinely do, and if you get the same flow in the donor pre and post taking care of the aneurysm, isn't that middle communicator anastomosis superfluous? I think that's what he's asking, and I'm asking the same question.
Yeah, I think the short answer is it's possible. Like if you did the flow measurements, you might find reason not to do it. But here's the rationale. You've got 2 dead ends that have essentially just their connection to the aneurysm. And so by taking them off and sewing them together, there's absolutely no additional ischemia time. And you get potential benefit by creating this connection. So in that one case I showed you, there's no risk and there's potential upside that you can't foresee because the flow dynamic could change depending upon the demand on each of those 2 trunks. The second thing I would say is that in some cases, you know, the other middle communicating connections, you actually have to create that, because if you put in a bypass, one of those slides of mine showed a bypass, a high flow bypass going into one of the 2 trunks. So in that case, you have to create a communication to the other one in order for the flow to get from one recipient to the other recipient that's coming out of that aneurysm. So in some cases, it's absolutely necessary.
Mike, Adam Arthur is with us. Adam, good to have you. He'd like to ask you, how do you know, regarding your remark, whether it's a blister or a dissection pre-op? Do you know pre-op if it's a blister?
Yeah, the answer is you can't know. And by the way, hi, Adam. I think you just have to look at it, and you have to sort of get down to it. You have to survey. And even when you've got an aneurysm, a true blister aneurysm that's encased by thrombus, you may still not know whether that's a blister underneath it or a pseudoaneurysm. So in those cases, it's very hard to tell. If you get down on it, like in I think the case that Jacques showed, you could actually see a wall, and you know that that's actually a blister as opposed to a pseudoaneurysm.
Yeah, Mike, I think with the binder ring bypass, is there a risk that the vessel can subside? Oh, same question. They're very worried your binder thing is going to fall back on the nerves again.
Yeah, well, so to be fair, I don't know. I am following this guy. We'll see. But if you think about the underlying pathology, in this disease, the arteries get bigger over time. They don't get smaller. So
right. I
when
agree
you reroute them and the pathologic process continues, it's only going to get further from the nerve now that you've
it's going to compress the fifth nerve next, and then you can do it.
Then we can do an entire posterior fossa binder ring.
Right.
Dan, I think you had started typing an answer. I'm not sure if you want to tackle the question about could someone...
Yeah, I tried to answer some of them earlier on, but I'm happy to answer them verbally.
Yeah, no, I think they're asking perhaps about my case, whether any of you would do a double barrel bypass, then proceed to trapping electively. But we heard your answers. All of you would do really a sling clip technique. So
yeah, but I think what you did was, I thought what you did was perfectly appropriate. I mean, notwithstanding the concern about vasospasm, but I think given the patient's age, the very minimal subarachnoid hemorrhage, they were at low risk. I think what you did was in retrospect, it was quite good.
And that wall abnormality really almost reached the bifurcation, and I just wasn't sure I would exclude it. And I'll never forget a case of mine and a case of Roberto, 2 cases of rebleeds after perhaps incomplete coverage with a sling, and it ballooned from the end.
Well, I will tell you, I always get delayed follow-up angiograms on these cases. I do these Gore-Tex slings on, and we've had one patient I can remember that in a very delayed fashion, when he was well past his subarachnoid hemorrhage, we actually put a pipeline in afterwards because it just looked a little irregular. He made a great recovery, and once he was safe to have dual antiplatelet therapy. So I think that disease is a difficult one to deal with, and I think long-term follow-up is important.
I think these are all the questions we need to cover. The others are repetitious to the same topics we covered. Any last comments to each other, or otherwise I cannot thank you enough for helping me restart these monthly things now, not weekly. Weekly is too much work. Monthly is very, very doable. Every third Thursday. You are among my closest friends, and I've all learned from all of you. Thank you for making the time to be with us, to teach these young, hungry brains. We've had more than 280 listening to you folks at one time, and I don't know how many on the second YouTube channel. And thank you so much. And see you, the audience, I'll see you March 18 with a skull-based topic as described. Guys, have a good night. Thank you.
Thanks. Good seeing everyone.